Hello dear students, today we'll see about the motor systems, pyramidal and extrapyramidal system. Part 1 will be only the pyramidal system. Motor impulses from the cerebral cortex reaches the muscles by two neurons. We call them as first order and second order also. The first order neuron is Upper Motor Neuron, UMN, and it is situated in the cerebral cortex. The second order neuron, which supplies the skeletal muscle, is located in the motor nuclei of the cranial nerves in the brainstem and in the anterior horn cells of the spinal cord. It will be called as the lower motor neuron, that is LMN. So, the motor impulses or the motor descending tract usually has two neurons. First order neuron, which is called as upper motor neuron, and second order neuron, which is called as lower motor neuron. The motor activity is controlled by two systems, which is pyramidal system and the extrapyramidal system. First, we will look into the pyramidal system. The fibers will originate from the pyramidal cells of the cerebral cortex. The pyramidal cells of the cerebral cortex. If you have seen the histology, you would have seen pyramidal cells located in the layers of the cerebral cortex. Okay, so that is the beginning of the pyramidal system. Okay, so these are the pyramidal cells. That's the beginning at the cerebral cortex. Next, we can see that 60% will arise from the motor area 4, which is in front of the central sulcus, okay, from the motor area number 4, and premotor area number 6. The 40% will also arise from the sensory area 3, 1, 2 and the adjacent parietal lobe. Then the axons of these cells will descend via the corona radiata. So first we said that they take origin from the pyramidal cells. Then it is the corona radiata over here. This arrangement, this fan-like arrangement is called corona radiata. Then it is the anterior capsule, internal capsule, and it's called as genu. Okay, so this region is the genu over here. Okay, then also it is related to the anterior two-third of the posterior limb of the internal capsule, anterior two-third of the posterior limb of the internal capsule. Okay, so if you would draw the internal capsule like this is the anterior limb, this is the genu, this is the posterior limb. So the pyramidal fibers will pass through genu and the anterior two-third of the posterior limb of the internal capsule. And also, if you know the motor homunculus, okay, here the face is represented at this place, and then you can see that it is the thumb and the upper part of the body, and then the lower limb will be represented on the medial side usually. The same way in the genu also, the face will be represented, and then comes the other parts of the body. Okay, this is called as laminar arrangement of the fibers. Then it passes through the middle 3/5 of the basis pedunculi. Okay, so next it is passing through the midbrain. Okay, and then it passes through the pons and through the medulla, and finally comes to the spinal cord. Okay, so it is the same tract we're talking about, the pyramidal tract. Okay, it's also called as cortico-spinal tract because it starts in the cortex and it is ending in the spinal cord. Cortico-spinal tract. Okay, before it terminates on the lower motor neuron. So this is the beginning, the The cell body is right here in the cerebral cortex, and then it passes through all this which we have just described. So first is cerebral cortex, then then the corona radiata, then it's the genu, the anterior two-third of the posterior limb of the internal capsule, then it is basis pedunculi, then a part in the pons, in the medulla, then it comes to the spinal cord. Okay, then it comes to the spinal cord. So now on the way we can see that it is giving the cortico-nuclear fibers. Cortico-nuclear. So what does it mean? It is coming from the cortex and it's going to the nucleus. So it is giving at the midbrain. It is giving nerves or supply to the third nerve and the fourth nerve. Okay, if you remember, third nerve is oculomotor nerve and fourth nerve is trochlear nerve at the midbrain. Then at pons, it will give supply to the fifth nerve, that is the trigeminal nerve, and the seventh nerve, that is the facial nerve. It will give branches only to the motor cranial nerves. Okay, only to the motor cranial nerves. Then at the medulla, it will give to the ninth nerve, that is the glossopharyngeal nerve, 10th vagus nerve, 11th is spinal accessory nerve, 12th is the hypoglossal nerve. So all these branches together are they called as the cortico-nuclear fibers. Cortico-nuclear fibers. Okay, and then at the lower level of the medulla, you can see the lower level of the medulla. Okay, if I would trace one fiber, I'm just going all the way down. At the lower level of the medulla, it is crossing. Okay, it is crossing to the opposite side, it goes down, and then at the spinal cord, okay, at the spinal cord it is called as the lateral cortico-spinal tract, and these are the crossed fibers. As you can notice here, there is crossing over here. Okay, and then you will also notice that 20% of the fibers do not cross, and they are forming the anterior cortico-spinal tract. Okay, so this is the section at the internal capsule. We can see that the position of the pyramidal fibers at the genu and the anterior two-third of the posterior limb. So again we'll just trace it. So this is the cerebral cortex at this level, the beginning of the pyramidal fibers. It passes through corona radiata, then the internal capsule. The internal capsule is a very narrow space where these fibers have to pass between the basal ganglia and thalamus. So it's very common to have any kind of injuries or compression at this level. Then it goes down, and this is called as the crus cerebri of the midbrain. Then at the pons, it is called as basis pontis, and it will give the fibers, that is, it will give to the, we've already seen that it may give to the third nerve, to the fourth nerve, then it may give to the at the level of the pons, it may give to fifth nerve or the seventh nerve. Okay, remember it is crossing and it is going to give the cortico-nuclear fibers. Then at the medulla, it is called as pyramidal decussation. The word decussation means crossing. So you can see that the fiber is crossing, and then it goes to this is the section of the spinal cord. So in the spinal cord, it is called as lateral cortico-spinal tract. Which are the crossed fibers. Okay, and the 20%, this is 80% of the fibers will cross. 20% of the fibers do not cross, they directly descend down. Okay, and they are called as anterior cortico-spinal tract. These are uncrossed. So let us also further look into the terms upper motor neuron. So upper motor neuron means it extends from the cerebral cortex till the nucleus, that is the cranial nerve nuclei, or till the anterior horn cells. Okay, so all this is called as upper motor neuron. From the once it has synapsed at the cranial nerves, then onwards, if it is suppose the third nerve nucleus over here, this is the fourth nerve nucleus. Okay, and then if it has synapsed, then the second order starts from there. It will be this, for the cranial nerves, this will be called as lower motor neuron. And for the musculature, upper limb or lower limb, it will be, here it is called as lower motor neuron from the anterior horn cells or ventral horn cells. Okay, so this is upper motor neuron from the cerebral cortex till the cranial nerve nuclei or till the um, anterior horn cells, and from the anterior horn cells towards the muscle, okay, it is called as lower motor neuron. Lower motor neuron, and the same way from here, from the cranial nerve nuclei till the muscle it has to supply, it is called as lower motor neuron. So if you have a lesion anywhere here, it will be called as upper motor neuron lesion. And if you have a lesion after the cranial nerve nuclei, okay, at the level of the cranial nerve nuclei, it will be called as lower motor neuron lesion. Or if it is here after the level of the anterior horn cells, it is called as lower motor neuron lesion. Okay, now there is another concept related to the crossing of the fibers. So if the lesion is at this level, if the lesion is at this level here, let us say this is the lesion, it is before the crossing of the before the crossing or before the decussation of the fibers, then the lesion, if it is, suppose the lesion is before the level of the crossing of the fibers, the lesion will be or the affected side will be opposite, it will be contralateral side. Okay, so if this is the right side, no, this is the left side, okay, left side there is lesion, the effect will be on the contralateral side, it is if it is before the level of the decussation. If the lesion here, okay, for example the lesion is here, now it will be still called upper motor neuron lesion, but it is below the level of decussation, below the level of decussation. If it is below the level of decussation, then it will be affecting the ipsilateral side, it will be affecting the ipsilateral side. So you understand that the lesion is here now on for example this is on the is belonging to the right side. Now it is, the lesion is on the right side, and the nerve sorry, the arm which is going to be affected, upper limb which is going to be affected, will also be on the right side. Okay, so it also depends on the level of the decussation. If the upper motor neuron lesion is above the level of decussation, then it is contralateral side affected. If the lesion is below the level of decussation, then it is ipsilateral side affected. Okay, ipsilateral upper motor neuron lesion. And obviously if it is lower motor neuron lesion, it is usually ipsilateral affected, it is affecting the same side, it's going to affect the same side. So let's look into the cortico-nuclear fibers and the cortico-spinal tract. The cortico-nuclear fibers, the fibers which terminate in the midbrain, they have a specific name, it's called cortico-mesencephalic. And if they terminate in the pons, it is called as cortico-pontine. And if it is in the medulla, it's called as cortico-bulbar tract. So together they are all called as cortico-nuclear. So specifically they can be called as cortico-mesencephalic, cortico-pontine and cortico-bulbar. And remember, they are going only to the motor cranial nerves. All these tracts cross to the opposite side before synapsing on the concerned cranial nerve nuclei. At the lower medulla, that is 80 to 90% of the fibers will cross to the opposite side. It's called as decussation. It forms the lateral cortico-spinal tract, whereas 10 to 20% remains uncrossed, and it's called as the ventral or anterior cortico-spinal tract. The pyramidal fibers which synapse on the anterior horn cells is called as cortico-spinal tract. The uncrossed fibers, which is the anterior cortico-spinal tract, eventually they will cross to the opposite side at the various levels before they synapse. The neurons and their axons of cortico-mesencephalic, cortico-pontine corticobulbar, and cortico-spinal tract. They are all called as upper motor neuron. The function of the pyramidal system is important role in the initiation of the voluntary movement, and it is usually non-stereotyped. Destruction impairs the voluntary activity of the finer movements than the gross movements. Finer movements like writing, painting, okay. And here you can see that this is the hemiplegic gait, okay. This is one of the gait related to the hemiplegia, related to affection of the pyramidal system, and you can see that he's not able to move his upper limb, and he actually has to move his lower limb in such a circle so that he can walk forwards. And it's obvious that it is the right side of the body which is affected. Comparison between the upper motor neuron lesion and lower motor neuron lesion. In both, you will see that there is loss of voluntary movement. There is increased tone and rigidity of the muscles, and it is called as spastic paralysis in upper motor neuron lesion. In lower motor neuron lesion, it is called loss of muscle tone and flaccid paralysis. Flaccid. Whereas in upper motor neuron lesion, he has exaggerated tendon reflexes, and in lower motor neuron lesion, there is absence of tendons reflex. There is hypertrophy of the muscle, so the muscle bulk may increase, whereas there is atrophy of the muscles in lower motor neuron lesion. There is extensor plantar reflex, okay, this is positive. In upper motor neuron lesion, there is no such reflex related to the lower motor neuron lesion. We will see what is this reflex now. This is a normal reflex of a normal adult. So this is how we are supposed to strike the aspect of the foot, and you will see that the first toe and all the other toes will actually try to do dorsiflexion, okay. Now you can see a positive Babinski sign. This is also called Babinski sign. Extensor plantar reflex is also called as Babinski sign. However, it is positive for infants within 1 year or 2 years, and also it is seen in upper motor neuron lesion. It will be positive. So this is what, when you would strike the foot, okay, when you strike the foot, you would notice that there is upward movement of the first toe and fanning of the other toes. So this is called as Babinski sign positive. Now we notice that there is lateral cortico-spinal tract, which is the crossed fibers, the decussated fibers at the lower level of the medulla, which has crossed, and it forms the lateral cortico-spinal tract. This is a section of the spinal cord in which you can see that this is the location for the lateral cortico-spinal tract. Whereas the uncrossed fibers, they come along the anterior cortico-spinal tract, and this is the location for it. All what you're seeing red in color and which is labeled are all the descending tracts, okay. So lateral cortico-spinal tract, anterior cortico-spinal tract related to the pyramidal system. However, just quickly look into the spinal cord also. I will say that this is the dorsal horn, which is related to the sensory. Then if you have a lateral horn, it will be related to the autonomic nerve system, and this is the ventral horn over here. Also, it can be called as the anterior horn, and the cells which originate from here are called as the anterior horn cells, and this is the beginning of the second order neuron or the lower motor neuron, okay. Now there are different levels of spinal cord, and the section of the spinal cord looks different. So if we would have a lesion at the thoracic level. For example, at the thoracic level we have the lesion. So at the level of the lesion, it will be a lower motor neuron type of lesion, and below the level of lesion it would be an upper motor type of lesion. Okay, so what does this mean? That like you have to understand that the white fibers, whatever you're seeing, the white area, this is the white fibers. The white fibers, they will either they will be descending or ascending fibers. So you can see that this region there is lots of white fibers. In the cervical region there is more of white fibers when compared to the gray matter, which is the edge shape inside. And then the fibers have to, like we said, it has to keep going down or up. And when we go lower down to the sacral region, there is less number of white fibers when compared to the gray matter. Okay, the gray matter is more, because you see the fibers have to only come from the, or sensations have to only come or go towards the lower limb. Okay, but if you take the cervical cord, for example, it has to go to both the upper limb, thorax, and the lower limb. Okay, so that's why the fibers will be more, the white matter will be more related to the cervical section. Okay, so now I hope it's clear. Now if you have a lesion at the thoracic level, for example, the lower motor neuron type of lesion at the level, okay, at the level you will have lower motor neuron type of lesion, whereas below the level the patient will show upper motor neuron type of lesion, because the fibers going towards the like lower limb has been affected. Okay, now we will see about the facial nerve lesion. Okay, facial nerve lesion, that is the seventh nerve lesion. Okay, and location is close to the stylomastoid foramen. This foramen is between the styloid process and the mastoid process. Okay, this is the exit of the facial nerve, and once it exits, it gives the 5 branches which you're very aware of, which are called as the temporal. Okay, then you have the zygomatic, buccal, upper buccal, lower buccal, marginal mandibular, and the cervical branch. Okay, so this is this diagram or this the clinical picture shows that there is a facial palsy. The name of this palsy is called facial palsy, and you can see that one half of his face is affected. Okay, so it is actually the left side which is affected, and this is actually a lower motor neuron type of lesion. Okay, so the 5 branches which I just told you, it supplies all the facial muscles, right? So on the affected side, what are the symptoms you will see? There will be loss of forehead wrinkling. Okay, so there is loss of wrinkling on this side because of affection of the occipitofrontalis muscle. There is incomplete closure of the eyes, and also there could be upward rolling of the eyeball, as you can notice here. Okay, this is related to the nerve supplied to the orbicularis oculi. There's lack of facial expression on this side. Okay, we are talking about the left side is affected here. Okay, so all the zygomaticus major, minor, buccinator, all these muscles are affected. And notice that the angle of mouth is deviated to the opposite side. Okay, so you can see that the angle of the mouth is going to the opposite side. That's because the opposite side is normal and it is pulling it. Okay, so it is, the angle of the mouth will go to the right side. Okay, and there will also be sometimes dribbling of saliva, and also food can get collected in his vestibule. These are actually the functions of the buccinator muscle used to help in emptying the vestibule. Okay, so this is what you will see in a lower motor neuron lesion. Complete half of the face will be affected. Okay, however, the facial nerve also supplies the anterior two-third of the tongue, taste to the anterior two-third of the tongue, and also gives secretomotor fibers to the nasal, the sublingual, submandibular glands, and they will not be affected. Okay, because we are talking about the lesion close to the stylomastoid foramen, so it's only going to affect the muscles of the face. Okay, this is very important to remember, that the bilateral connections are present for all the cranial motor nuclei except the lower part of the facial nucleus and the part of the hypoglossal nucleus that supplies the genioglossus. Except these two parts, the lower part of the facial nucleus and the hypoglossal nucleus which supplies the genioglossus, all other cranial motor nuclei are having bilateral connections, We'll see the next slide to understand more about this. So here we can see this diagram in which this is the facial nerve nucleus. Okay, this is the facial nerve nucleus which you're seeing, and if you divide into two parts, this is the upper part, okay, and this is the lower part, okay, and you can notice that the upper part is supplied by two halves, by the right side and the left side, whereas the lower part of the nucleus is only supplied by the contralateral side. Okay, it's only receiving fibers from one side, not from the two sides, or not from bilateral connections. So in upper motor neuron lesion, as you can see in this lady, if you would look into this half of the face, it is same. Again it is the left side of the face which is affected, and here it is seen that the wrinkling of the forehead, okay, wrinkling of the forehead will be present, and even she can do closure of the eyes, proper closure of the eyes. Okay, so only the lower half of the face is going to be affected, okay. The reason is because the upper motor neuron nerve lesion of the facial nerve, okay, in which the occipitofrontalis muscle, which is supposed to supply the or supposed to help in the wrinkling of the forehead, and orbicularis oculi, which helps in closure of the eye, are having bilateral innervation by the cortico-nuclear tract, and therefore it escapes the paralysis. So these two, the occipitofrontalis and the orbicularis oculi, they both will be normal. Okay, they both will function normally. The reason is because they have bilateral innervation. As it's clear in this diagram. Okay, so you can see that there is bilateral innervation from both the sides. Okay, if you want to say this is the right side and this is the left side, so this upper part of the face and these two muscles, they are getting innervation from both the sides. Okay, hence the patient will be able to frown and close the eyelids tight. Okay, so that means the function is well preserved, which he cannot do in lower motor neuron lesion, as we saw in the previous diagram, that in the lower motor neuron lesion the complete half of the face is affected. Both these muscles, occipitofrontalis, orbicularis oculi, and all the other muscles are also affected. Okay, and the reason is because it is having unilateral innervation. Okay, now let's look into the hypoglossal nerve, which is the 12th nerve, and the 12th nerve supplies all the muscles of the tongue except the palatoglossus, which is supplied by the pharyngeal plexus. So here we can see that there is a right-sided lesion, okay, and it has caused hemiparalysis and hemiatrophy. Okay, so there you can see that the muscle has atrophied. It is not the same bulk like on the other side. This is the left side, right? And there is paralysis. And once we ask the patient to protrude the tongue moves. Okay, the protruded tongue deviates to the side of the lesion, to the right side. Okay, so once we ask the patient to protrude the tongue will move towards the side of the lesion, and in this case it is the right side. Okay, so in lower motor neuron lesion of the 12th nerve, it produces atrophy of the tongue on the affected side. When the patient protrudes the tongue, it will deviate to the affected side, and we also call it as licks the side of the lesion. Okay, this is due to unopposed action of the genioglossus on the normal side. the part of the hypoglossus that supplies the genioglossus has unilateral innervation. Okay, so because it has the unilateral innervation, we can see that it is moving to the affected side. Okay, thank you.